All right, welcome back to The Explainer. Today, we're diving deep into a bacterium that's as fascinating as it is frustrating for clinicians and labs, Actinomyces graevenitzii. Let's jump right in.
This quote really nails it. This bug's whole game is about pretending to be something else. Things like lung cancer or tuberculosis. That ability to masquerade is exactly what makes it such a tough diagnostic puzzle, and why it's so critical for us in the lab to have it on our radar.
Just a quick heads up on our sources. Everything we're covering today was put together from a pretty comprehensive Gemini deep search. If you want to see some amazing images of what this organism actually looks like, you've got to check out MicroCanvas. And for all the nitty-gritty citations, the full list is in the linked notebook.
So here's our game plan. We'll start with why we call it the Great Mimicker, then get into its taxonomy and the diseases it causes. After that, we'll hit the lab bench grind, cover modern ID methods, tackle treatment challenges, and finish up with prevention and the key takeaways.
So how does a bug that's normally just hanging out in our mouths turn into a serious bad guy? Well, it's a classic story of an opportunist waiting for its moment. At its core, what are we dealing with? It's a gram-positive rod, a normal resident of our oral pharynx. Now, the key words here are fastidious, meaning it's a piggy eater, and facultative anaerobe, so it loves low-oxygen environments. It's perfectly happy to stay put, but the real trouble starts when it gets a chance to go somewhere it doesn't belong. The infection follows a pretty clear playbook. First, something has to break our mucosal barrier. Think a dental procedure, some kind of trauma, or even just poor oral hygiene. Once it's in, it finds a nice, cozy, low-oxygen spot and sets up shop. From there, it's a slow, chronic burn, creating this incredibly dense, hard fibrosis that famously doesn't respect anatomical boundaries. And sometimes, deep inside those abscesses, you'll find the classic sulfur granules, which, by the way, aren't sulfur at all, just tangled clumps of the bacteria.
So what kind of trouble does it cause? Well, the number one presentation is pulmonary actinomycosis, usually after someone aspirates some of their oral secretions. But it can also cause empyema, that classic lumpy jaw syndrome, and even pelvic infections, especially linked to long-term IUDs. And in some really rare cases, we see it causing severe esophageal problems in kids and even bacteremia.
And this brings us right back to its nickname, the Great Mimicker. You look at a CT scan of a lung with actinomycosis, and what you see, this slow-growing, cavitating mass, can look identical to lung cancer. It's a huge problem. It means patients often end up getting invasive biopsies or even having parts of their lung removed, all before anyone realizes the real cause is a treatable bacterium. Okay, so if it's so tricky to diagnose clinically, how do we pin down the real culprit? Let's head over to the lab bench, because this is where the microbiologist truly becomes the lead detective in this mystery. Under the microscope, you're looking for a branching, beaded, gram-positive rod. Now, it can look a whole lot like Nocardia, which makes your next step absolutely crucial, the modified acid-fast stain. Actinomyces is not acid-fast. This is the test that separates it from Nocardia, and that distinction has massive implications for treatment. It's a fork in the road you can't afford to miss.
Now, if there is one single thing I want you to burn into your memory about culturing this organism, it is this number: 10 days. The most common single reason a diagnosis is missed is because anaerobic plates are tossed out too soon. You just have to be patient and give this slow grower time. To get this thing to grow, you've got to give it the VIP treatment. It needs an anaerobic or microaerophilic environment, and it really loves a little extra CO2. Using a selective media like anaerobic CNA agar is a total game changer because it knocks back all the fast-growing gram-negatives that would otherwise just overrun the plate. If you wait it out, after a good few days, you'll be rewarded with those beautiful, classic molar tooth or breadcrumb colonies. So once you have something growing, how do you know it's Actinomyces graevenitzii and not one of its close relatives? Well, a few key biochemical tests can sort that out. It's catalase negative, which separates it from Actinomyces viscosus, and just as important, it doesn't ferment mannitol or xylose, and that's how you tell it apart from Actinomyces newi. Look, all that classic microbiology is essential, but let's be honest, modern molecular methods have completely changed the game. We can now get certainty in minutes or hours, not days. The way to think about it is that we have two main tools that play different but equally important roles. 16S rRNA gene sequencing, that's your gold standard. It gives you the definitive species-level ID, and it's invaluable for those tough culture-negative cases. But for your day-to-day rapid ID from a colony, MALDI-TOF MS is the workhorse.
It's fast, it's reliable, and it gives you an answer in minutes, as long as you keep that library updated. Okay, let's talk treatment. This is one of those areas where old habits and assumptions can really get you into trouble. The idea that Actinomyces is just susceptible to everything? Well, Actinomyces graevenitzii didn't get that memo. It breaks some of the old rules.
So the big one is right at the top of this table. Actinomyces graevenitzii is intrinsically resistant to metronidazole. Think about that. A common empiric regimen for something like aspiration pneumonia often includes metronidazole for anaerobic coverage. Against this organism, it provides absolutely zero activity. Same goes for aminoglycosides, fluoroquinolones, and TMP-SMX. They just don't work.
And here is another huge clinical red flag. We all think of Actinomyces israelii as being reliably sensitive to beta-lactams, but some strains of Actinomyces graevenitzii have shown resistance to ceftriaxone. That's a really big deal, since ceftriaxone is a go-to drug for so many infections. So what's the right way to treat it? The Dutch swab guidelines give us a really solid framework. It's a two-phase attack. You start with a long induction of high-dose IV penicillin G. We're talking 2 to 6 weeks to really penetrate that dense fibrotic tissue. Then you transition to a very long oral step-down with amoxicillin, often for 6 to 12 months to make sure it doesn't come back. And for patients with a penicillin allergy, doxycycline is the way to go.
For kids, the philosophy is exactly the same. Hit it hard and for a long time. The only real difference is that everything is based on weight. We're still talking very high doses of IV penicillin G to start, followed by a high-dose oral amoxicillin course for the long haul. Okay, let's bring it all home. How do we keep these infections from happening in the first place? And what are the absolute must-know points that we should all take away from this? The good news on the infection control front is that this is pretty straightforward. It's an endogenous infection. It comes from the patient's own flora, so it's not transmitted from person to person. Standard precautions are all you need. In the hospital, the big focus is on making sure bronchoscopes are meticulously cleaned to avoid any pseudo-outbreaks. And for patients, the best prevention is simple: good oral hygiene to keep that bacterial load down. So, if you remember nothing else, please remember these 4 things. 1. Suspect it. Anytime you hear about a chronic lung disease that's mimicking cancer, this bug should be on your differential. 2. Culture it correctly. Hold those anaerobic plates for at least 10 days. 3. Identify it accurately. Use your modern molecular tools. And 4. Advocate for aggressive long-term treatment. This isn't a 2-week course of antibiotics. This is months of high-dose penicillin. And I just want to leave you with this question to mull over. When you think about how good this organism is at hiding and how hard it is to grow, it makes you wonder, how many people out there with a diagnosis like idiopathic pulmonary fibrosis or a culture-negative pneumonia that just won't go away might actually have a missed but completely treatable Actinomyces graevenitzii infection? It's a pretty sobering thought. And that wraps up our deep dive on Actinomyces graevenitzii. Thanks so much for joining me today. If you found this useful, please hit that subscribe button and definitely leave your questions or any feedback you have in the comments below. I really do look forward to seeing you all next time.